Good afternoon, good morning, or good evening, depending on where you are. Welcome to this webinar, which is about the launch of the global position paper on midwifery models of care. And we have an exciting panel lined up. First of all, we'll have some opening remarks from Dr. Tedros, followed by Dr. Caroline Homer. We will then have an overview in two parts of the position paper and an interactive panel discussion looking at how some of these models are already being implemented. So we'll have a discussion around the midwifery model of care in Uganda and the midwifery model of care in Ethiopia. And following that, we'll have a Q&A, which will be moderated by Alison Moran, and then we'll come back to next steps and wrap up this session for today. So first of all, I'd like to introduce Dr. Tedros Adhanom Ghebreyesus, the Director General for WHO, to give his opening remarks by video for today's session. I think I'm not hearing the sound. Can someone confirm that?
Indeed, whoever is launching the video needs to not be on mute on their screen.
Estimated that universal high-quality midwifery. Dear colleagues and friends, midwives play a crucial role in providing high-quality care for women, newborns, and adolescents. It's estimated that universal high-quality midwifery care in all countries could save up to 4.3 million lives annually by 2035. To realize that vision, WHO is supporting countries to transition to sustainable midwifery models of care where midwives are the main providers for women and newborns from before pregnancy through to the postnatal period. The global position paper we're launching today outlines what these models are and why they're so important. Midwifery models of care are a cost-effective investment in equity, gender equality, and universal health coverage. I thank all those who have contributed to this document, which will help to shape the future of maternal and newborn health and well-being. And thank you all for your commitment and dedication to maximizing the role of midwives and creating a healthier future for women, newborns, families, and communities. I thank you.
Thank you very much, Dr. Tedros. Always very inspiring. And we'll now go to the second round of opening remarks by Professor Caroline Homer, who is the Deputy Director for Gender Equity, Diversity and Inclusion, as well as co-head of the Global Women's and Newborns Health Group at the Burnet Institute, as well as the chair of the STAGE, the Strategic Technical Advisory Group, experts for maternal, newborn, child and adolescent health and nutrition. And Caroline, may I also congratulate you on your recent Princess Srinagar Indra Award that you received. But over to you.
Thank you so much, Anshu, and thank you for those kind words. Welcome, everybody. Good morning, good evening, good afternoon. It's wonderful to have so many people online with us to launch this really important position paper. So as Anshu said, I chair the STAGE, and this work has been led by the STAGE, the Strategic Technical Advisory Group for Maternal, Newborn, Child, Adolescent Health and Nutrition with WHO. And this work has been supported by the STAGE members and a STAGE working group for midwifery models of care. And that was co-chaired by Professor Jane Sandel from STAGE, who you're going to hear from this evening as well, or this morning, and Dr. Sally Pearman, the Chief Executive of ICM, International Confederation of Midwives. We also had an amazing amount of members from around the world, really, joining the working group to help develop this position paper. And I also want to sincerely thank Justine Lelez, who's led the work through WHO, and you'll hear from Justine in a little while. This is the culmination of 3 years of work. It's not the end. We have another piece of work, an implementation toolkit or an implementation guide that will come out next year. But we thought the position paper is so important because it will provide the evidence to countries, and it will start the journey for many countries. It will continue the journey for other countries around midwifery models of care. So thank you again for joining us. Thank you to all of you who contributed to being part of this really important work. And I look forward to the panel discussion and your questions as the session goes on. Over to you, Anshu.
Thank you very much, Caroline, and for your guidance throughout this process. It's been a year of hard work, I think, but we're very pleased with the results that we got out of it. So we'll now hear a little bit more about what this transition to midwifery models of care actually means, and we'll get an overview of the WHO Global Position Paper presented by Professor Jane Sandel, CBE, who is a stage member, who is the co-chair, as Caroline mentioned, of the Stage Midwifery Working Group, but also a professor of women's social science and women's health at King's College London. And she is the first author of the Cochrane Review on the Continuity of Midwife Care, which was published recently this year in March 24. Together with Justine Lenné, who is our very own maternal health consultant in our department, and who is a midwife and global health specialist, and who helped coordinate this work. Over to you, Jane and Justine.
Thank you very much, Anshu. Can you see the screen?
Yes, we can.
Perfect. Thank you very much, Anshu. And before starting, please write your questions on the Q&A on Zoom, and we will answer at the end of this webinar. So I'm really honored to co-present with Jane Sandel today. She, along with Sally Pearman, have been great leaders in co-chairing this work. In the document and presentation, midwives refers both to midwives and nurse midwives. Also, the word women, when we refer to pregnancy, childbirth, and the postnatal period, is intended to include adolescent girls. It was noted that the terms of women and mothers are intended to be inclusive of all those who self-identified as women and or who give birth. While the majority of people who are pregnant or can give birth are cisgender women who were born and identified as female, our vision is also inclusive of the experiences of transgender men and other gender diverse people who have the reproductive capacity to give birth. So why do we need a global position paper on midwifery models of care? Well, in 2024, there is still a high maternal and newborn mortality and stillbirths. And during this webinar, more than 500 maternal deaths, newborn deaths, and stillbirths will happen. This maternal newborn mortality and morbidity has lifelong impacts on women, newborns, but also on partners, families, and communities. More than 50% of maternal and newborn mortality is due to poor quality of care because of limited resources available, disrespectful care, and in some settings, over-medicalization with overuse of unnecessary interventions. There is a cost-effective strategy to improve women and newborns' health outcomes and experience of care. And this is for governments to transition to midwifery models of care. But when we started this work, there was no common understanding of the concept. And this is why this global position paper aims at providing policymakers and healthcare leaders with comprehensive information about midwifery models of care, the evidence-based, but also the agreed definition and the guiding principles. This is in order to strengthen the quality of maternal and newborn care and ultimately contribute to improved outcomes for women and newborns. This document is authored and published by WHO. It's based and aligned with WHO documents and strategies, including the strategic direction for nursing and midwifery. It's a collaborative effort with the contribution of over 90 individuals and partners, among which UNFPA, UNICEF, ICM, CIAN, JIPIGO, Burnett Institute, COIN, IPA, and the Bill and Melinda Gates Foundation. As Caroline Homer mentioned, it has been endorsed by WHO stage. The document has 5 different chapters. The first one is the background and provides an overview of the global context in reproductive, maternal, newborn, and adolescent health. The second chapter presents the definition. Who is a midwife? What do midwives do? What are midwifery models of care? You may know these answers, but if you ask around, you won't have the same answers twice. The third chapter is about the case for midwifery models of care. What does it mean? It's the rationale. Why should governments transition to midwifery models of care? What is the evidence behind this? The fourth chapter is about the guiding principles that we are going to present in a minute. And the fifth chapter is the conclusion. We base the definition and scope of practice of midwives in this document on the International Standardized Classification of Occupation from the International Labour Organization. It's very important in midwifery models of care that midwives autonomously provide care across their full scope of practice. So it was important to define what is the full scope of midwife practice. For models of care, we started the journey from this definition, the WHO definition. It's a conceptualization of how health services should be delivered. So it includes the processes of care, the organization of providers, the management of services, and it's supported by the identification of roles and responsibilities, of different platforms and providers along the pathways of care. So we started from this definition of model of care, and then we decided on the recipients of care for midwifery model of care, which should be all women and newborns, regardless of the risk. The time frame includes pre-pregnancy, pregnancy, childbirth, and the postnatal period. The service coverage includes maternal and newborn care. It does not mean that midwives don't have a broader scope of practice, but it means that for this definition, it's the service coverage included. The main care providers should be educated, regulated, and licensed midwives. They should autonomously provide care and coordinate care across their full scope of practice. This does not mean that they don't work alone, they don't. They work as part of interdisciplinary teams with an approach to care that is aligned with the midwifery philosophy of care that has been so well defined in the midwifery Lancet series for midwifery, The service delivery platforms are all levels of care and all contexts, including the most difficult contexts in crisis and humanitarian settings. But it requires a functional and enabling health system. So this is the global definition of midwifery models of care. You can have it on the document. The document is made available at the moment on WHO webpage, but it's exactly what I've just explained in the last slide. The guiding principles are 5. The first guiding principle is that the care in midwifery models of care is equitable and human rights based, and it enables access for all women and newborns. The second guiding principle is that the care is person-centered and respectful. And what we retrieve from most of the literature is that it encourages a trusting relationship and partnership between women and midwives. The third guiding principle is that the care is of high quality and aligned with the midwifery philosophy of care. The care is provided and coordinated by autonomous, educated, regulated, and supported midwives in all settings and at all levels of the health system. And finally, the care is integrated and midwives work within interdisciplinary teams with nurses, doctors, and other health workers in networks of care. So every midwifery model of care should strive to be informed by these guiding principles. Over to you, Jane.
Thank you, Justine. So I'm going to talk about the evidence base that we're drawing upon to provide the rationale. The key point is that when women have access to midwives, it saves lives. It increases the humanization of care. It contributes to a better society because we're advancing human capital, and there are some economic benefits. So the first piece of evidence comes out of the Lancet series, and here we have modeled how many lives are saved if every woman has access to a midwife delivering evidence-based interventions. So if we achieved universal coverage by 2035, we could avoid 67% of maternal deaths, 64% of newborn deaths, and 65% of stillbirths, even with a modest increase at 10%, we could still avoid a substantial number of mother and baby deaths. Next slide, please. The other piece of evidence we're drawing on is the evidence on midwifery, midwife continuity care. This is where women have access to a small team of midwives throughout their pregnancy journey who follows them across the care system. This is the result of a Cochrane review, which was updated this year, where we compared 18,000 women in trials who had this type of care compared to other models of care. It improves the care experiences of women. It improves some maternal health outcomes, and there are cost savings. Thank you, Justine.
Thank you very much, Jane. In conclusion, this global position paper is a new reference international document that is published today by WHO, but developed with over 90 individuals and partners under the stage. It clarifies what midwifery models of care are and presents their guiding principles. And finally, it explains why governments should choose to transition to these models of care and why it is critical for women, newborns, partners, but also families and communities. Thank you. Over to you, Anshu.
Thank you very much, Justine and Jane. And I see there are already questions coming in, and very good questions, because it's actually highlighting exactly why we started this work on request by the stage, and why the stage took this work forward. So we'll now come to the second part of the session of the webinar, and we're going to look into two particular case studies, let's say. The first one is going to be from Uganda, and we're going to have a discussion with Jane Frances Acham, who is the Principal Nursing Officer for Midwifery Services in the Ministry of Health in Uganda. And Mrs. Acham started her position at the Ministry of Health in 2021. She is the highest midwifery leader. It's the highest midwifery leadership position in the country. And she is in charge of midwifery services and referred to as the Chief Midwife Officer, which is sometimes referred to as the Chief Midwife Officer in other countries. So welcome to the webinar. And we would very much like to hear from you, as you are the Principal Nursing Officer for Midwifery Services. What is the pathway into the midwifery model of care in your country?
Yeah, thank you so much. Good afternoon, everyone. I have been introduced. And hello, can you get me?
Yes, we can hear you.
Yes, transitioning to a midwifery model of care is promising pathway improving the lives So in Uganda, the article explores the journey of a pregnant woman through a lens of midwifery care, highlighting the antenatal, intrapartum, and postnatal phases. Our mothers in the community, when they are pregnant, come to a health facility. And when the primary health caregiver is a midwife, when they come to a health facility, though pregnant, in labor, postnatal, the primary contact is a midwife. So I want to highlight what goes through when a midwife comes through antenatal. The midwife comes through antenatal, meets a midwife who will take care of her. In Uganda, the antenatal visits are 8. So the first visit is to confirm pregnancy and assess the mother's health. And then here a midwife does many things. She does health education and counseling. She does routine tests for the mother. She examines the mother, does a birth plan with the mother, and she screens for high-risk cases. If a mother has no risk, she continues attending the 8 antenatals visits with the midwife. If a mother is identified to be high risk, the midwife in a primary setting refers her to a secondary setting where there is a doctor. And in a secondary setting, the doctor works hand in hand in collaboration with a midwife to manage this mother, and the midwife is in center of the management. The doctor sees this mother, plans together with the midwife how to manage the mother. So that happens in antenatal. Same in intrapartum, a midwife walks to the maternity center, the birth center, and meets a midwife who examines her and identifies either the mother is high risk or no risk. If no risk, the midwife monitors a mother in labor throughout the period. If a mother has high risk, the midwife informs the doctor who will come and they manage this mother as a team. And a midwife is still in the center of the management. The doctor does a cesarean section, but all the care is done by the midwife with the other team health workers. And that is what the midwives do. She continues monitoring her mother, the progress of labor until she delivers. When it is postnatal, the same midwife receives the mother in postnatal, observes the mother, take vitals, and do all the necessary care the mother needs. If a mother gets a complication, you find that the midwife informs the doctor, and the doctor comes and they manage as a team with other stakeholders. The midwives in Uganda are trained in recognition of emergencies, how to manage them. Emergencies like postpartum hemorrhage, preeclampsia, and the other emergencies that can arise. And they help support the mother throughout pregnancy, labor, and cesarean. So that is the role, the pathway of a mother. After postnatal, the midwife goes ahead to carry out immunization of this baby until the baby grows to the age of 5 years. So that is briefly the journey of a pregnant mother, the pathway of a pregnant mother in Uganda. Thank you.
Thank you so much, Jane, for highlighting how a pregnant woman enters into the services and is accompanied throughout the pregnancy, interpartum care, and postnatal care by that midwife. Could you say something about what you think are the strengths and potentially also some areas for improvement in the model that you currently have?
Thank you so much. In Uganda, midwives are the main caregivers for women and newborns during pregnancy, childbirth, and postnatal period. Most of essential care is given by midwives. So the strength we have that the midwives work autonomously within the scope of practice. We have a scope of practice for midwives, and our midwives adhere to the scope of practice. The community-based approach tailored care to women and communities, and the midwives observe the cultural preferences of mothers in the community. So that is a strength for us. Then the model is based on the interdisciplinary and integrated approach of care. In the interdisciplinary, we have to work with all other healthcare workers, and our services are integrated in all services that are offered in a hospital. So we believe that is a very good strength. And then midwives are trained to identify risks and collaborate with doctors and healthcare workers when high-risk patients arise. And there is a mutual trust and respect between midwives and doctors, and even other healthcare workers. They show respect. The doctors respect midwives, the midwives respect the doctors, and this is allowing us to provide the best care for women in our setting. But we have challenges amidst our work. You find that midwifery models on care encompass more than just a midwife, and it involves system strengthening and creating enabling environment for midwives and their teams to provide high quality care. This includes infrastructure, the availability of necessary commodities, and addressing workforce shortages and work overload. Those are the challenges we have. When you look at the infrastructure in our country, we don't have very good birthing centers. We normally get stock out of drugs, and when you talk of workload, our midwives deliver between 1 to 500, 375 to 500 mothers in a year, which is not in relation to the WHO standard of 1 to 175. So the workload and the shortages are there. So some of the issues we need to be addressed, they need to improve on the infrastructure. We need the government to avail the commodities, essential drugs, supplies and commodities, and then also to address the issue of shortage of staff, of midwives in the facilities, such that we are able to deliver our work efficiently. I think that is all what I have. Thank you so much.
Thank you so much, Ms. Acham. And you're highlighting a couple of crucial things around, an enabling environment such as infrastructure, having commodities, and also the right number of human resources available. We had a report a few years ago that highlighted the shortage of 900,000 midwives globally. And I think you are addressing that point as well, to say that there is a need for more midwives. I see there are a lot of questions in the chat, in the Q&A also around leadership that we'll come to later. And I hope that all our speakers will be available to address some of those questions. So we'll now come to the case study, let's say, around the continuity of midwife model in Ethiopia. And we'll be speaking to Dr. Solomon Haile-Meskel, who is a midwife, who is the assistant professor of midwifery at the Debre Berhan University and the president of the Ethiopian Midwives Association. And we'll look a little bit about what this continuity model of care means that has been implemented in North Shoa zone of the Amhara region. So, Professor Solomon, Dr. Solomon, maybe you could say, as you are the assistant professor of midwifery and the current president of the Ethiopian Association of Midwives, how you implemented this continuity of midwife care model, and sort of maybe what were the success factors in order to do so. Over to you. You're on mute.
Okay, thank you so much for having this wonderful opportunity. Good morning, good afternoon, good evening, everyone in this group. So thank you so much. I'm Solomon Haile Meskel from Ethiopia, and I will present the case study which was part of my PhD study when I was a PhD student at University of Uganda. So in this study, we have been studying a new way of providing care for pregnant women in Ethiopia. And the study was conducted between August 2019 up to September 2020 in 4 randomly selected hospitals in North Shore Zone, Amhara region. And in that study, we wanted to compare the 2 different models of care by selecting low-risk pregnant mothers. So the first model, which was considered to be an intervention or a model, was continuity of midwife care model. In this model of care, each pregnant woman is expected to receive care by the same midwife or a backup midwife throughout the pregnancy, during childbirth, and after the baby is born. And the second model of care, which we consider as a control hospital, is the existed model of care in Ethiopia. We call it the shared model of care. Sometimes it is also called as the standard model of care. In this model of care, woman is expected to receive care starting from antenatal care up to the postnatal care by different healthcare providers who are assigned and work in the antenatal care, in the intrapartum, and in the postnatal care. So for this, we divided 1,178 pregnant mothers into 2 equal groups. So 589 women were assigned to the intervention hospital, which is the continuity of midwife care model, and the other 589 pregnant mothers were assigned to the shared model of care or in the control hospitals. And in the continuity of care model group, we group midwives working in the selected health facilities into small groups. Around 4 up to 8 midwives were grouped together and provide continuity of care model for about 37 up to 38 pregnant mothers in each midwife, so that they provide continuity of care starting from the antenatal care up to the postnatal period. Then we train the midwife on how to provide midwifery continuity of care model, and how they organize themselves, and the philosophy of the model were provided as a training or as an intervention for these midwives. And they provide care starting from antenatal care up to the postnatal period. What was our main outcomes? The results were explicit, and the continuity of care model can significantly improve outcomes for mothers and babies, while increasing women's satisfaction with care. It also positively affects how often women used healthcare services, with more women benefiting from the prenatal visit and the postnatal contact within the continuity of care model. In this model, that is in midwifery continuity of care model, an increased number of women gave birth vaginally compared to the control group or the standard model of care. And they were also more likely to start breastfeeding within 1 hour of giving birth, and there were a high satisfaction rate with their care provided by midwives. Almost 87% of pregnant mothers were satisfied overall in the care they received from antenatal care up to the postnatal period. And when we see the outcome related with newborn, preterm births were reduced by 61% in the midwifery care model, and the need for vacuum-assisted births was also reduced by 58%, and the use of episiotomy was also reduced by 74% in the intervention hospital or in a woman who received midwifery continuity of care model. Newborns had also better health outcomes. There was a 59% reduction in low Apgar score at 5 minutes, and a 50% reduction in admission to the neonatal intensive care unit. So in continuity of care model, midwife cared 95% of women were cared by the same midwife during the labor and birth or during the intrapartum period. With regard to how we manage...
Oh, please continue.
yeah, with regard to how we manage the implementations of the model, so with a generous support from the UNFPA in Ethiopian office, with its financial support, now the Ethiopian Midwifery Association work closely with the Ministry of Health on developing an implementation guideline for implementing the midwifery model of care in the Ethiopian context. That is the most important thing we have achieved after we have these kinds of findings in our country. So the result is promising, and following our evidence, the Ethiopian Ministry of Health has conducted an implementation with the Ethiopian Midwifery Association, and to have the Ethiopian context in transition to midwifery model of care. And we are also sharing our findings to consider implementation and resetting it, because our evidence shows that there is a comparable result in implementing midwifery model of care even in lower and middle-income countries. Thank you so much.
Thank you very much, Dr. Solomon, and particularly very exciting that you did a kind of case control study and could clearly show what the benefits are. And the benefits that you're highlighting are also the benefits that we have seen out of previous reviews with, reduced rates of episiotomy, improved preterm birth rates, as improved satisfaction, etc. So very exciting to see, and also exciting to note that this is now being scaled up by the Ministry of Health. So we also, thank you very much. We now also want to listen actually to the voice of the woman. And we have Zuzana Kryszkova with us, who is the chairwoman of the Women's Circles from Slovakia. And Zuzana represents women's voices and was also part of the State Midwifery Working Group. And so, Zuzana, maybe we can hear from you a little bit as an activist for women and a grassroots organization in Slovakia, the Women's Circles. And you advocate for human rights-based, evidence-based, and women-centered care throughout the pregnancy, childbirth, and postnatal care. So what is your experience around the current state of maternal and newborn health in relation to midwifery models of care in Slovakia?
Greetings, everyone. Thank you very much. I'm honored to represent Women's Circles today. So in Slovakia, most of the 50,000 annual births take place in hospitals, and approximately 1/3 of them is by cesarean section. So this raising concerns about excessive medical interventions. Currently, it's obstetricians who are the main care providers for pregnant women in Slovakia. And midwifery is a recognized profession, and Slovak midwives are highly educated with bachelor's degree or higher, and their competencies are with alliance to the EU directives. Their practical role in maternal care is often limited with restricted opportunities for independent practice. There has been some encouraging development in the last few years, some legislative efforts and discussions, and also some hospitals are allowing midwives to take more active role in assisting physiological births. But we have several challenges that are deeply rooted in our healthcare system. First, there is a shortage of midwives in our country. A lot of practicing midwives are nearing retirement age, and there just aren't enough new graduates that could replace them. And also, midwives spend a lot of time doing administrative tasks, so it leaves them little time for the direct patient care. So this, of course, affects the quality of care, but also can provide, and it also can lead to job dissatisfaction and burnout for midwives. But perhaps the biggest challenge that we have here is how midwives are viewed by the public, how they are seen. So public often views midwives as assistants to doctors rather than independent professionals. So this view limits their authority and ability to use all their training. Thank you. Over.
Thanks, so much, and for highlighting that, you know, there's a real need for leadership in amongst midwives also. I think it's what I sense from you. And what do you think about the midwifery model of care, and how that would meet the women's needs? Could you say a little bit more about that?
Yes, I think that by implementing midwifery models of care, we can really create a more woman-centered, accessible, and comprehensive maternity care system in Slovakia and globally. Well, this approach has the potential to improve health outcomes, increase satisfaction with care, and empower women throughout their reproductive journeys. Midwifery models of care offer a promising solution for many challenges that we have here in Slovakia. For example, care in Slovakia is often fragmented and task-oriented. The care during childbirth in hospitals is organized more like an assembly line in a factory, and the system is oriented to the needs of the people who provide these tasks rather than on the needs of birthing women. And this approach often leads to that the women are felt alone, not seen, not heard, and it also can lead to mistreatment and abuse in childbirth. The person-centered care and respectful care, encouraging trusting relationship and partnership between women and midwives, which are the core principles of midwifery models, can change this, especially in the continuity of midwife care, as Solomon just described. The trusting relationship between women and a midwife throughout pregnancy, birth, and in the postnatal period. This enables women to feel more comfortable asking questions, sharing concerns, and making informed decisions about their care. And it also reduces anxiety. Continuity of care is especially important for women who have experienced pregnancy loss or have a traumatic birth experience, or are survivors of sexual assault or any kind of abuse or trauma, because these women may need extra sensitivity and support. This strong trusting relationship and open communication between women and midwives also promote personalized education and support women to identify warning signs that may require medical attention. It empowers women to appropriately recognize the changes in their physical and emotional well-being during the time of pregnancy, childbirth, and the postnatal period. It also, this approach reduces unnecessary interventions and ensures if the interventions are needed, that they are provided in a timely manner. Another problem is access to healthcare services, particularly for women in rural areas or from marginalized communities, because they may face some barriers like language barriers, transportation costs, childcare issues. So bringing midwifery into the communities, this can help overcome these obstacles and ensure more women and newborns can access essential healthcare. Midwifery models, in my opinion, can also help to address the big gap that we have in Slovakia in the postnatal care, because women usually leave hospital after 3 to 4 days after they give birth in hospital, and the follow-up checkup with their obstetrician or gynecologist is usually scheduled at the end of the postnatal period. So instead of this, women could have comprehensive support from their midwife, and she can monitor their physical recovery, support breastfeeding, guiding women on pelvic floor exercises, and detecting early signs of postnatal depression, anxiety, and providing early help or referral when needed. So as a human rights activist, I see the biggest benefit of midwifery models of care in their potential to empower women, because these models respect women's rights to make informed decisions about their care, honoring their autonomy and preferences. So we are talking about better healthcare and at the same time upholding women's fundamental human rights during one of the most significant experiences of our lives. I think that the WHO position paper on midwifery models of care will be an essential resource because it provides crucial information about what these models entail, what are the core principles. And this document can help policymakers, healthcare providers, and activists like me to better understand and articulate the key components of midwifery models of care. And it can also help to facilitate and inform discussion and decision-making to make our healthcare system better. Thank you.
Thank you so much, Susanna, and for highlighting how this can empower women to have a better experience of care and of their pregnancy, as well as, for example, a few concrete examples, improve postnatal care, etc. So we've had the exciting panel discussions, and we'll now go over to the Q&A part because there are many questions in the chat. And the Q&A will be moderated by Dr. Alison Moran, who is the Unit Head for Maternal Health in the Department for Maternal, Newborn, Child and Adolescent Health in WHO and Aging in WHO. Alison, over to you.
Great. Thank you so much, Anshu. And thank you so much to our wonderful panelists for that really rich discussion. And as Anshu mentioned, we have quite a few questions coming in through the Q&A box. So thank you to those of you who had put some questions in here. So because we have limited time, what I think what we'll try to do is that we will try to address some of the larger themes that are coming through. And I will maybe read out one of the questions and then ask our panelists to respond, because a lot of the questions are about how to make this work in different contexts, both in low and middle income settings, but also in higher income settings. So I think maybe, as Anshu mentioned, we can start with the question around leadership. There have been quite a few questions about how can we really expand and elevate midwifery as a distinct profession, but also strengthen the leadership of midwives so that they have a role at the policy-making table and making decisions about how these models are supported and implemented and invested in within different country contexts. So maybe I can ask first Jane Francis to give a few thoughts on that, and then we'll go to Solomon and to Susanna. So over to Jane Francis.
Yeah, thank you. Thank you so much. Thank you for the question. For me, I would recommend that the issue of leadership is key in midwifery model of care. We need to have the leadership of midwifery right from the national level to the grassroots level. And then we also look at the continuity of care, which is not able in many countries that they are able to implement because of things like work overload, shortages like that. But advocating for the midwifery model of care is very key, and we've seen in many countries it has worked to improve the lives of mothers and babies. Thank you. Over to you.
Sorry, thank you, Jane Francis. I was muted. Maybe Solomon, over to you. You have any thoughts to add to this around how we can strengthen leadership of midwives within midwifery models of care?
Okay, thank you so much. Midwifery leadership is really a big concern or problem in midwifery profession, yeah, obviously. But we want to strengthen the leadership contributions of midwives. So, far as my experience is concerned, when we allow midwives to work in a midwifery model of care, obviously it will also improve the leadership ability and the leadership ability of midwives. Because in continuity of care model, the midwife will have the chance to exercise their profession autonomously and within their scope of practice. So with this situation, the midwives will have the highest probability to participate in leadership. The first one, in midwifery model of care, the midwife who coordinate and provide care for the pregnant mother, starting from the antenatal care up to the postnatal care, will be the most important responsible individual. The model by itself allows or encourages midwives to take responsibility. So whenever there is responsibility, obviously, they will be in a good position to exercise their ability in leadership. So we need to provide training or a capacity building and communication and awareness for midwives to participate and to work in leadership. But implementing midwifery model of care by itself has also its own positive contribution for midwives to become a leader or to participate in leadership.
Great. Thank you so much, Solomon. Susanna, any thoughts from your side?
Thank you. As a women's activist, I don't really want to speak for midwives. I think there are their own pensions with their own ideas how things should be done. But from the perspective of the public, maybe I will address that as women. So what we can do is raise more awareness about what is midwife, what midwives do, that they are not nurses, because in Slovakia a lot of time people exchange nurses and midwives. And I think one of the things we can do is showing stories from women's perspective, how the care from midwife affected them and the satisfaction with care. I think this is maybe our role, and I hope it will support also the government to look more into these models, because we need them, as I described. We really need to make some changes in our country. Thank you.
Yeah, thank you so much. It's really great to hear that perspective as well. Thank you so much for sharing that. I wanted to move on to the next set of questions. There's quite a lot of interest in better understanding how we can work within interdisciplinary teams. And so some of the examples from Uganda and Ethiopia, and then some insights from you as well, Susanna, about how the midwives within each of your settings are able to work with different types of providers, whether it's obstetricians or pediatricians or nurses or others, to ensure that collaborative teamwork piece, which is so crucial to the midwifery models of care. So I wonder if you can talk a little bit about that in each of your settings, to just provide a few more details. So maybe over to you first, Jane Francis.
Yeah, thank you so much. In Uganda, we normally advocate for teamwork in whatever you are doing as a midwife. And what you mean by teamwork, you work with other teams, with other healthcare providers, doctors, nurses, to manage a mother, because the midwife alone cannot manage. Like for a case of Uganda, a high-risk mother needs maybe a doctor's attention. He needs to go to theater. Midwives are not operating. A mother needs blood transfusion. A mother needs anesthesia. So those are the teams. We have newborn resuscitation, newborn care, whereby there are other teams, nurses that are trained in newborn care. So we work as a team, we collaborate, we consult, and then communicate effectively for us to work as a team to bring this midwife, to bring this mother and the baby to have a good life. That's what we do in Uganda, working as a team in order to achieve the best goal. Thank you.
Great. Thank you so much, Jane Francis. It's really great to hear about your experience in Uganda and how you really fostered that culture of teamwork and collaboration, which is so crucial. Over to you, Solomon.
Okay, thank you so much. Yeah, from the very beginning, when we say midwifery model of care, it really allows multidisciplinary teamwork. So in this model of care, midwives are the most important and integral part of the system that coordinate and provide care for the pregnant mother. But if there is complication, if there is a need to refer the woman to the highest levels of care, so that there has to be obstetricians and other important healthcare providers that will provide the care for that pregnant mother. So in midwifery model of care, we really encourage and promote interdisciplinary approaches. Whenever there is a need to have different healthcare providers, obviously the mother or the woman needs to have that individual. So midwives will coordinate and provide the majority of care for the pregnant mother, but if there is complication, they need to consult and work with obstetricians and other important healthcare providers. And they will also work with other individuals, for example, with laboratory professionals, because there might be a need to have laboratory investigations and other important healthcare providers also. So it allows multidisciplinary teamwork, and we also encourage that one. But there has to be someone who is going to coordinate and provide the care for that pregnant mother. So the most important thing is, if the woman is develops complication and needs a referral, the midwife has to be there with the mother whenever there is what complication or whenever there is a referral systems to other health facilities. That's the most important. Otherwise, teamwork has to be there. Yeah.
Well, that's great. Thank you so much, Solomon. It's really very helpful. Thank you. Over to you, Susanna. Anything you would like to add?
Yes, our system is really set up more for obstetricians. Even some know they are not regarding healthcare, but are regarding some social benefits and so on, are really pushing women towards obstetrics care, or gynecology care. So during the pregnancy, women usually see only gynecologists or obstetrician, even though in many of the offices there are also midwives working. Women don't know what midwives are, and midwives are not taking care of them. It's really rare to be midwives taking care of women during a pregnancy. And in a hospital, I would give an example from hospitals that are like more approaching the midwifery care. Usually when woman is admitting to the hospital that she's giving birth, she is admitted both by a midwife and both by an obstetrician. And if they are in agreement that she's the low risk, that the birth will probably be physiological, usually the midwife cares about this woman, and it depends on the hospital whether during the second stage they will be presented and who will be there. Usually it's obstetrician and neonatologist. A lot of people are there. And after the birth, woman is transferred to the maternity ward, where again the care is fragmented. So midwives care about women, but neonatological nurses care about the newborn. So we really have the fragmented system, and often women say like they are not communicating enough between them. And also from our research that we did a few years back, it shows that yes, these are like two lines of the system. They are not that good in communicating, but they are working under the same roof and in the same hospital. Thank you.
Yeah, thank you so much, Susanna, for sharing that. That's really helpful, and things that we have to think about how we address. So I think with that, we're getting towards the end. We just have a few minutes left. So I just wanted to respond quickly. There are many questions in here about advocacy and how WHO and other partners can help work with, member states and other partners to advocate for implementing and or transitioning to these midwifery models of care. So that's something we'd be very happy to support ourselves with all the partners, UNFPA, ICM, and all the others who are contributing to this work. We are currently developing we're calling it a midwifery accelerator that will help think about what are the, why you should invest in this model, and some messages that can help support with negotiations with policymakers. So happy to share more about that as that work moves forward. But I think that will be a great opportunity. And then please do reach out to us. We're happy to help support you in any of your advocacy efforts so that we can really work together on trying to make these midwifery models of care a reality. And so let me just move on then to the last few slides where we're going to talk about the next steps. So as you heard today, the position paper is out, which summarizes all the evidence that you can use for advocacy, as well as other discussions and policy dialogues in your countries, and we're happy to support with that. And then we will be and are working on now an implementation guidance. If you can go to the next slide, please, Justine. Oh, yes, thank you. So implementation guidance that will, as many of you asked, how to do this. So this guidance will really go through, as Caroline mentioned as well at the outset, how to move forward and how to move this process forward using some concrete tools. And so that work will also include some case studies about how different countries have put these models into place. So hopefully that will be helpful for you as well as we move to the next steps. The next slide, please. Justine. It's just we're hoping to get that finalized by early next year, and look forward to continue working with you so we can ensure all your questions and comments are incorporated into that guidance so that we can all work together to move this forward. So with that, next slide, please. I know we're at time, but I just, again, wanted to thank everybody for joining today and for the really thoughtful and rich discussion and questions that you put out there. This is the beginning of the discussion about midwifery models of care. We're very excited to have the position paper and the evidence and the case for midwifery models of care published under the leadership of our strategic advisory group, the STAGE, with support from the co-chairs and all the partner organizations that have made this happen. I also really want to thank our panelists for sharing their experiences, and I hope that we can continue to have more discussions with colleagues who are working on transitioning to these types of models of care in their different contexts. And so perhaps what I'm hearing from this too is a need for more discussion about how to make this happen as we start to shape and finalize implementation guidance so that we can really address all of the questions and comments that have been raised. The recording and presentation are available shortly. The links are here on the slide and also in the Q&A and the chat. We are also be posting a video of Dr. Tedros's video with some more graphics and animations that will be available as well on social media and through these links. And thank you again to our colleagues who have really made this happen behind the scenes. So thank you very much to Justine and Bene and Merve and everybody else who has made the technology happen today, as well as everything in place. So I don't know, Anshu, if you want to add anything before we officially close.
No, so thanks a lot. I thought it was a great webinar, and just like you, I'd like to thank all participants and as well as all panel members who joined us today. Thank you. And do reach out to us. Maybe, I don't know, we can have the MCH department email address also when we share the slides there, so people can reach out to the department and we can continue the discussion.
Great. Thank you so much, everyone. Have a great rest of your day. Look forward to being in touch.
Thank you.
Thank you and goodbye.
High quality midwifery care in all countries could save up to 4.3 million lives annually by 2035. To realize that vision, WHO is supporting countries to transition to sustainable midwifery models of care where midwives are the main providers for women and newborns from before pregnancy